Go ahead and get started so that we can stay on time. My name is Dr. Karen Smith, and I'm one of the breast cancer oncologists with the Johns Hopkins Breast Cancer Program. And on behalf of Dr. Stearns and myself, co-directors of our Lunch and Learn series, Survive and Thrive, and our entire team, we'd like to welcome you to our first session. Can you please forward the slide, Jackie? So Jackie is on today. She is our program coordinator, and the rest of our planning committee is listed here. Also on the call today will be Jill Mull, who will be moderating the session with me, one of our patient navigators. Next slide, please. So we are really excited today to learn about COVID-19 and cancer lessons learned, presented by Dr. Tatiana Prowell. Dr. Prowell is well known to Johns Hopkins, and she's an associate professor of oncology in the Johns Hopkins School of Medicine. And she's also coming to us with her FDA hat, where she's the breast cancer scientific liaison at the Food and Drug Administration. And we're really excited to hear from her. We're also going to hear from Nicole Tucker-Smith, who is a patient representative who's going to be sharing her personal experiences with breast cancer treatment during the pandemic. Next slide, please, Jackie. So a few little notes about how the next session will go. The presentation will be first by Dr. Prowell, and that will last about 30 minutes. Next, we'll turn over to Nicole for a 5-minute presentation about her personal experiences. And then we will wrap up with a 20-minute live question and answer session. Participants, you are muted during the webinar, so you will not be able to speak. However, the way for you to communicate with us is to type your questions into either the chat box or the question and answer function. We will be monitoring that throughout the talk, so you can type them anytime. And then when it's time for the question and answer session, Jill and I will be reviewing and selecting the questions and posing them to Tatiana and Nicole for discussion. And then we'll wrap up right on time so that everybody can go back to their busy days. Next slide, please. One last point is that we would love to hear back from you about what you think of this webinar. Your feedback really helps us to plan for future programs and new initiatives. We will be sending you an email link shortly after the webinar to complete a brief evaluation, and we ask you to complete it if possible within 7 days. Your input really does matter. So with that, I think we'll switch slide sets over to Dr. Prowell's slides, and we'll get going on the presentation.
You can go all the way over to the left where it says from beginning. Oh.
Sorry.
No problem. While we're waiting for the slides, thank you so much to Dr. Stearns and to Dr. Smith and to everyone involved in planning and organizing this series for inviting me to be the kickoff speaker. I'm honored to be here with you talking about COVID-19 and cancer. What have we learned? So you can go all the way over to the left where it says from beginning and start from there. Thank you so much. So as you've already heard from Dr. Smith, my name is Tatiana Prowell. I'm an associate professor of oncology in the breast cancer program at Johns Hopkins and the breast cancer scientific liaison at the US Food and Drug Administration. Next slide. I have no financial relationships to disclose, and the opinions expressed are my own and don't necessarily represent those of the institutions with which I'm affiliated. Next slide. I'd like to start out by dedicating this talk actually to a member of my own family, Paul Constantine, who was known to us as Papa Doc, who is a very dear family member living with a hematological malignancy and continuing to work and practice as a family medicine physician in California at the start of the pandemic, who actually acquired COVID-19 while still working and ultimately passed away from COVID-19 on Good Friday of last year. He was one of the most outstanding clinicians and human beings I've ever met. And he was really the reason that I have started thinking a lot about COVID-19 and cancer instead of just continuing to do my usual work in breast oncology. So I'd like to start out by just talking about the global burden of COVID-19. These are numbers from yesterday, and I felt sad as I put this screenshot on the slide, knowing that by today, this number would be worse. We would likely lose another 1,000 people overnight. But so far globally, we've had about 150 million confirmed cases of SARS-CoV-2 infection. And with that, more than 3.1 million lives lost. The United States has the unfortunate distinction of being the leader in the world's confirmed cases of SARS-CoV-2, as well as in deaths, where we are approaching 575,000 lives confirmed lost to COVID-19. Next slide, please. So, I want to begin by talking about health and equity in the pandemic, because I think that we're going to come back to this later in the talk, and we need to keep this at the focus of everything as we think about this pandemic. The losses that we have seen, both in terms of people becoming infected and maybe missing work or developing lingering symptoms, but also people hospitalized, lives lost, have disproportionately fallen on people of color. So this is compared to white patients, and if you look at cases, you see that some groups have been disproportionately infected, so developed cases of SARS-CoV-2, particularly Hispanic or Latino persons were twice as likely as white patients, and American Indian and Alaskan Native persons were about 1.5 times as likely. But where you really see the disparity, where you really see the impact, is actually in the patients who developed severe illness with COVID-19, or who even died of COVID-19, where you see here that for Black patients, they have a 3-fold greater risk of being hospitalized, almost a 2-fold greater risk of dying. Likewise, a Hispanic or Latino person, 3-fold likelihood of being hospitalized, almost 2.5 times as likely to die. And similarly with American Indian or Alaskan Native people. So it's important for us to start out by just remembering that the burdens of this pandemic have not fallen to a proportionate degree on everyone in the population. Next slide. When we think now about the impacts of COVID-19 on oncology, I want to begin with a broad view of this, thinking about the impacts on the whole oncology community, thinking about the impacts on the world, and then kind of zone in and think about impacts on individual patients and patient care. So, this is a slide from American Cancer Society. And if we think about all the ways that this pandemic have affected oncology care, the first part, and this is familiar to everybody who's watching this webinar, who's a patient or who's a caregiver, as well as to anyone who is an oncology clinician, was reduced access to care. So for a number of reasons, including people's fear of infection, including redeployment of staff and resources to the care of patients with COVID-19 and away from other specialties, to issues of loss of jobs or people being furloughed from jobs, and many people having employer-provided health insurance, to shutdowns and social distancing that might have prevented people from being able to get their usual rides to a clinic visit. We saw across the board reduced access to care for people with cancer. We also saw reduced access, and you'll see this a little bit in the later slides, in terms of prevention and early detection or risk reduction and early detection. We saw fewer people being able to have their mammograms, being able to go have their pap smears, being able to go have their colonoscopies, or even just see their doctors for a regular cancer screening visit, an annual physical. And this has resulted in patients presenting with cancers, because of course the cancers still occur at the same pace, whether or not we're detecting them. It has resulted in both a backlog of patients with cancer, so more people kind of showing up once these restrictions on social distancing or restrictions on seeking medical care were lifted, but also presentation of patients with later stages of disease, more advanced cancers, more likely to have incurable disease. And that, of course, results in morbidity for patients, requirement for perhaps chemotherapy in a patient who's, if her tumor had been smaller, perhaps that wouldn't have been needed, or patients whose treatment now will be palliative and no longer curative because they presented with distant metastases. And all of these things contribute in different ways to increased cancer mortality. The next slide, please. So just to show you visually the impact of cancer screening, this is actually interesting. These are data from Epic Health Research Network. So Epic is one of the electronic health record companies. Many health systems use them. Johns Hopkins uses them. And although they've not published this data, they've actually done a lot of research during the pandemic. So this was just looking at the differences in cancer screening for 3 common cancers: breast cancer, colon cancer, cervical cancer, over the course of a 4-year period. So you see most of the lines kind of cluster in this fairly consistent place: 2017, 2018, 2019. And then when you see 2020, which is that violet colored line, you see this dramatic drop. People just having their screening mammography appointments canceled, people having their colonoscopy appointments canceled, people having their visits with their gynecologist canceled, or choosing to cancel them because they were concerned, understandably, about the risk of being exposed to SARS-CoV-2 in a healthcare setting. And what this has resulted in really just a short period of time, really just the period of a few months, was 285,000 estimated missed breast cancer screenings, almost 100,000 missed colon cancer screenings, almost 40,000 missed cervical cancer screenings. So again, just emphasizing this impact that we'll see in years to come on when cancers are being detected and the stages at which they're being picked up. Next slide, please. And with this, not unexpectedly, we've already seen dramatic falls in cancer diagnoses. So as I said before, people are still getting cancer at the same rate. There's no reason to think fewer people are getting cancer than would have had it this month had, something different happened in those last 4 weeks. So when we see these numbers in cancer diagnoses falling, that's not a cause for optimism. This is a cause for concern. So these bars, each of these bars, are looking at a 1-week period, really from the start of the pandemic in the US, effectively, over a period from the beginning of March to the middle of April. So this is not even a long period of time. And if you look at the cancers for which we have screening programs in place that are widely used, particularly breast cancer and colorectal cancer, you see that the drop in cancer diagnoses is really almost half or more. So very dramatic change, even just in that short term. This is still not fully recovered to baseline, as you'll see in later slides. Next slide, please. So this is modeling that the NCI director, Ned Sharpless, presented and published in Science last year on the predicted impact of these COVID-19 disruptions on cancer deaths over the next decade. And all of these bars here, basically where you should be if things were as normal, would be down there at the 0 line, right at the x-axis. So there would be no excess cancer deaths for colorectal cancer or breast cancer compared to usual. So everything that you see in those bars are extra deaths. So you're talking about as many as 5,000 or more extra deaths from breast cancer, every year over the next decade. And likewise, colorectal cancer, the impact is slightly smaller, 3,000 or 4,000 deaths, but we're going to see the long-lasting repercussions of this in the US and around the world over the next decade. Next slide, please. When we think about oncology research, again, any of you who participate in clinical trials, and certainly any of you who are involved in conducting or designing clinical trials, are well aware of this, but we also saw dramatic disruption to our clinical research infrastructure and machinery. So these lines are basically looking at the number of clinical trials that were launched, so totally new trials being started over different 1-year periods. And you see that the numbers start there with 2015 to 16, go up to 2019 to 20. And basically what you see is the most recent line, this turquoise line, the number just went down and down and down. And there's some changing over the course of the year, month by month, and that's normal. But if you look out on the right-hand side, you really get a sense of what a dramatic difference this is. 2018 to 2019 saw the launch of almost 400 new oncology clinical trials. We have fewer than 200 being launched for the 2019-2020 year. So this is about a 50% reduction in new clinical trials. And that, of course, is going to delay everything in our discovery for patients, in the development of new drugs accordingly. Next slide. When you look at existing clinical trials, we saw similar disruptions. So on the left there, you see a slide that was presented again by Dr. Sharpless at ASCO annual meeting last year, showing that accrual to NCI-sponsored trials fell by week there from 304 down to 191, and this is over a period of just a few months. So, not quite a 50% reduction, but probably a 40% reduction, very dramatic. And then on the right, if you see these two figures, which are from the same paper, this was a survey of institutions across the US, Europe, and Asia, asking them what's happening with your clinical trials during this several month period at the start of the pandemic. And what you see is that very few institutions in the US and Europe were able to continue to accrue their trials and conduct their trials on a normal pace. So Asia did the best there. About 60% of their trials continued on just like normal. But if you look at the US, 60% of the trials were accruing at a lower rate. In Europe, 86% of the trials, remember, Europe was hit hard very early, particularly in Italy, were accruing at a lower rate. And then we had a large percentage, 20% in the US and even 20% in Asia that just stopped accruing to clinical trials altogether. And these are cancer centers. So that's a very dramatic statement to say that enrollment in new clinical trials just absolutely stopped. One good thing that has come of all of this, though, is it has forced us to say, could we do clinical trials differently going forward in a way that makes them possible to be able to conduct when people can't necessarily get to cancer centers as they typically do? And so in that same paper, they actually surveyed these groups about what technologies or strategies were being utilized or being considered for clinical trials to enable them to proceed even in the disruption of the pandemic. And you see in the yellowish green, those were things that were being done or were planned to be done. The things in turquoise were things that they weren't doing yet or were unsure whether they would do. But what you see is that, somewhere between 50 and 82% of all of these different things are now being done or planned to do. Things like having virtual site visits, things like shipping oral study drugs to patients, things like having fewer site visits, having an alternative location, so allowing patients to switch clinical trial sites, which is ordinarily something that happens with great difficulty, if at all, telemedicine visits rather than bringing people in if it's not necessary to see them in person. So there's an opportunity for us to do better clinical research going forward. Next slide. So when we go down, sort of think about this as at an individual level, what's the impact on patients? And it's clear that people with cancer are at increased risk. So this is actually data from the COVID-19 and Cancer Registry, which is a multinational registry that is housed at Vanderbilt in the US, but has contributors from all around the world. And these are voluntarily submitted reports about patients. So clinicians enter their data about patients, their cancer type, their COVID-19 diagnosis, and the outcome, as well as demographic information about the patients. And what they have learned is that these things are associated with increased mortality for people who have COVID-19 and cancer, older patients, male patients, and we see that in people without cancer as well. Likewise with increasing comorbidity. So if you have both cancer and diabetes and heart failure, you're going to be at greater risk than someone with just cancer who gets a SARS-CoV-2 infection. People who have actively progressing cancer, so their cancer is not responding to treatment, or people who have a higher performance status score, meaning that they're less able to do their activities of daily living. They're more likely to be confined to a chair or a bed. And incidentally, use of hydroxychloroquine and azithromycin, and that's an important cautionary note. There were many people in the desperation of the early pandemic that said, these are FDA-approved drugs used for other things. We think they're probably pretty safe. Let's just try them. They might work. Before we had clinical trial data to support that. And in fact, use of that combination was actually associated with an increased risk of death at 30 days for people who had COVID-19, including people who had COVID-19 and cancer. Next slide. So subsequent to that registry data, there was a meta-analysis that included 13 studies and almost 3,000 patients that was able to quantify this a little bit better. And what they found was that the 30-day mortality of COVID-19 in people with cancer was about 15%. Between 1 in 7 and 1 in 8 people who had COVID-19 and cancer died. And the risk of this was greater for people who were sick enough to have to be hospitalized, where it was almost double inpatients, almost 1 in 3 with COVID-19 and cancer died. The risk was greater for people who had hematological malignancies, so that's things like leukemia, lymphoma, over those who had solid tumors. Again, older age and male sex were associated with increased risk, and active therapy, so being on current treatment, was associated with higher risk, but only in older patients. That relationship was not seen in younger patients. Next slide. So this figure may be a little bit challenging to follow. I want to make 2 points. So this is basically looking on the left, sort of in the bluish green colors, at people with solid tumors, and then on the right of each panel, people with hematological malignancies. And it's saying, what were the predictors of either mortality? So the top 2 images you see there are mortality. The bottom 2 images you see there are a composite endpoint of severe illness. So things like hospitalization, needing the ICU, needing to be put on a breathing machine, a ventilator. And what you see was that whether or not patients were NED with no evidence of disease, whether they had metastatic cancer that was stable or responding to treatment, or metastatic cancer that was progressing, and the type of therapy they're on, there wasn't dramatic difference in the risk of death. We do see that the risk of death is higher for patients with hematological malignancies across the board, and the risk of death is a little bit higher for those patients who have advanced cancer that's not responding to treatment. But we do see, when you look down at the bottom in the severe illness area, there, if you have patients who have hematological malignancies, the risk is far greater than those with solid tumors. And again, for people with metastatic cancer or metastatic cancer that's not responding, that risk is greater than those who have stable tumors. Next slide. So another concern has been about how long infection may last in people with cancer. So we know that what leads us to clear the virus from our blood is developing an antibody response to it. So those antibodies come along and they attach to the virus and they clear it away from the blood, clear it out of the bloodstream. And you may have heard these recommendations change from CDC over time. So initially we told people you need to wait 14 days after a test, and then subsequently that was changed to 10 days. And that is just recognizing that people don't continue to shed indefinitely, and we want to be able to let them out of isolation and be able to return to work and their family and so forth as soon as possible. Patients who have cancer don't form antibody responses to the virus as effectively, or to the vaccine as effectively, which I'll show you in later slides, and that leads them to have virus circulating in their bloodstream for longer. So there was detectable viral shedding for more than a month in patients with solid tumors, and for a little over 2 months in patients with hematological malignancies. And patients with hematological malignancies were less likely to ultimately form a detectable antibody response than those with solid tumors. Next slide. When we look by type of therapy about the likelihood of seroconversion, so seroconversion means forming those antibodies against the virus that we can then detect in a test. That's called seroconversion. So when we look at the likelihood of seroconverting by the type of therapy people were on, I want you to kind of focus on that third column there, which is OR, or odds ratio. So when you see that number is low, when it's less than 1, those are patients who are less likely to form antibodies. So what you see there is people who are on anti-CD20 therapy. So rituximab or Rituxan is a medicine that you may have heard of. It's used commonly for lymphoma and some other things. If you have people who had anti-CD20 therapy, if you have people who had stem cell transplants, so bone marrow transplants and so forth, they were much less likely, although these are small numbers of patients, they were much less likely to form any detectable antibody. In contrast, patients with hematological malignancies were more likely to form, patients with hematological malignancies and solid tumor malignancies were both likely to form antibodies over time, but this really depended on the nature of the therapy. So again, some of these therapies like anti-CD20 therapy and stem cell therapy are more commonly used in hematological malignancies, and in patients who are on those, you're less likely to see them form an effective antibody response. Interestingly, for patients with endocrine therapy, you see that 70 out of 71, so if you look at those first 2 columns, 70 out of 71 of those formed effective antibodies. So we don't know if this is a real finding, or if this just reflects that in the sense that that somehow endocrine therapy is helping people form an antibody response, or if it just means that people on endocrine therapy are very similar to the general population in terms of their risk of not clearing this virus. Likewise with immunotherapy, 17 people who were on immunotherapy formed antibodies. So again, good news for people who are on those therapies. Next slide. So part of why this is important is actually on a societal level. So what you see there in the left panel is a single individual patient. So this was a patient with a chronic leukemia, hematological malignancy, who was hospitalized for 101 days with SARS-CoV-2 infection and ultimately died on that 101st day. And while he was hospitalized, they were actually continuing to test him to see if he was clearing the virus and then sequencing the virus that they continued to detect. He actually never cleared the virus. So what you see is that the things that are labeled there off on the right with the various letters and numbers, basically these are variants that are named. And what you see is the higher those levels are in the graph, the more of these variants this patient formed. And so the arrows at the top in black remdesivir the second time, convalescent plasma the first and second time, and then in the second panel, convalescent plasma for a third time with a third dose of remdesivir. What we saw was that as this patient continued to be infected with SARS-CoV-2, and particularly when he got convalescent plasma, which is providing the plasma of recovered patients to try to help clear the virus from their system, so it's providing antibody to them, this patient's virus started changing rapidly and producing a lot more different variants, essentially mutating in real time in a single patient the way it would ordinarily take multiple patients passing through for a virus to change. And what I show you here on the right side of the slide is actually the belief that the UK variant, B117, if you've heard of that, it's now the dominant variant in the US, may have actually come from a single immunocompromised patient in whom the clearance of the virus never happened, was not possible, and therefore that individual just accumulated mutations as the virus continued to grow and replicate in that individual. So this is important for us from a public health standpoint. If we have immunocompromised patients who are getting infected and not clearing the virus, that actually places the entire world at risk. Next slide. So this is why it's unfortunate. Some of you who are familiar with my past work know that I'm very passionate about greater inclusion of diverse populations in clinical trials. And when I say diverse, I mean diverse in every way, including diverse in the nature of their diseases. And that includes within oncology, including people with things like HIV and hepatitis and brain metastases. In COVID-19 clinical trials for the vaccines, patients with cancer were effectively excluded from almost all of them. So you can see the top row there is Moderna, the second one is Pfizer BioNTech, and the third one is the Johnson & Johnson. So the 3 authorized vaccines in the US. And you can see in that 5th column over the exclusion criteria that pertain to cancer patients. And this unfortunately resulted in most people with cancer not being able to participate in the clinical trials. So we don't have data on efficacy and safety in them from any of these randomized trials at this point. Next slide. So what has happened is subsequently, because we didn't have that data in these clinical trials, people have started doing smaller studies where they're looking at immunogenicity. They're basically saying, are these patients forming an antibody response and are they forming a T cell response? So antibodies and T cells are sort of the 2 arms of the immune system. And this is particularly looking at the Pfizer vaccine, which is one of the 2 mRNA vaccines, Moderna being the other one. But basically what you see here is they compared healthcare workers, so people without cancer, as the control group, people with solid tumors, and then people with hematological cancers. The top part is looking at antibody response. The bottom part is looking at T cell response. And what you see is that if people get only 1 dose, healthcare workers form antibodies in 94% of cases, T cell responses in 82% of cases. If you look at patients with solid tumors, only 38% are forming antibodies. Patients with hematological malignancies, only 18% are forming antibodies. The numbers for T cell responses are better, but still not as good as people without cancer. If you don't have a boost, what you see is that you actually lose some of that response. So if people just get that first dose at week 1, and they are due for a dose at week 3, but they don't go get it, if you go measure their antibodies and their T cell responses 2 weeks later after they've missed that second dose, those responses are falling. So they're already losing protection from the virus, from the vaccine. If they, on the other hand, get that second dose on day 21 as they're supposed to, their numbers are still not quite as good as the healthcare workers, but they get much closer to that. So just to emphasize that it is super important if you're a person with cancer to get vaccinated and make sure you go get that second dose on time. Next slide. So this is looking at side effects. So again, because patients weren't included in those randomized trials, everyone said, you know, are they going to respond differently to the vaccines? Will they have more side effects? And this is actually reassuring data. So the flip side of forming a less effective immune response from the standpoint of protection from the virus is that you're also less likely to have side effects, because most of the side effects are due to revving up the immune system. So this is looking at, on the left side, those first two circles or pie charts there after the first dose of the Pfizer vaccine. The second two circles there on the right side of the slide are after that second dose at day 21. And in orange are people who had no side effects whatsoever. So the cancer cohort, the group of people with cancer, more than half of them had absolutely no symptoms at all with the first dose, and almost 3/4 of them had no symptoms with the second dose. In contrast, you see that the healthy cohort, that's the second and the fourth circle, people without cancer, were more likely to have side effects. Next slide. And if you look at the nature of these specific side effects, and I apologize that this is small for all of you, but this is just looking at the particular ones with mRNA vaccines. So again, this is like Pfizer or Moderna. People with cancer who are on the left side of the slide. So the first dose is at the top, the second dose is at the bottom, people with cancer on the left, healthy controls are on the right. What you see is the group on the left, the people with cancer, have smaller bars throughout, and that means fewer side effects. So they actually had, again, fewer adverse events than healthy control patients, and the most common were just mild injection site pain, so pain in the arm muscle, and fatigue. Next slide. It is important to know that COVID-19 vaccines can cause temporary lymph node enlargement. And I apologize, I moved the picture, so the arrow is not where it should be now, but you can clearly see just to the left of that red arrow, that's a big lymph node at the base of the neck. So we know that these lymph nodes, because they do rev up the immune system, can cause these vaccines, because they do rev up the immune system, can cause enlarged lymph nodes. It can happen after the first or the second dose. They are usually in the armpit. They can be in the neck or above or below the collarbone as well. They are usually, but not always, on the same side as the vaccine. They can last anywhere from a day or two to 2 to 3 weeks. And it's important to make sure that patients are aware of this so that they don't get worried when they see enlarged lymph nodes. And it's important to make sure clinicians and people reading their imaging studies are aware, so that we don't incorrectly conclude that a person's cancer is progressing, or that they, maybe if they don't have cancer, that perhaps this person does have cancer, and send them, for example, for a biopsy of a lymph node that they never needed. And because of that, several imaging groups have put out recommendations to consider timing scans to occur several weeks after imaging studies have been done, and for things that are not urgent. So I'm not talking about a situation like you have a new breast mass and someone says, go get a mammogram. Please don't delay that. But if you're going for a screening mammogram, for example, to consider delaying that for several weeks after the last dose of the vaccine, just so we don't get into this problem of being confused. What we don't know is whether or not this may predispose to lymphedema. Again, a shortcoming of the fact that people with cancer weren't included in those vaccine clinical trials. But based on that previous slide where we just see fewer side effects across the board, we're hopeful that this lymph node swelling may actually be less common in people with cancer. In fact, this photograph is from my colleague, Erica Hamilton, who's a breast oncologist in Tennessee with Sarah Cannon, and this is her own neck. She does not have cancer. This is her own neck showing her response after the second vaccine used with her permission. All right, next slide. So several groups have put out recommendations about vaccination in people with cancer, and this, I won't read all of these, but effectively what they say is that you should get vaccine, even if you're on active therapy, even if you have metastatic disease, whether or not it's progressing, no matter what, you should get it. The only time where you need to delay that would be people who are getting who have had stem cell transplants, bone marrow transplants, or who've gotten cellular therapies like CAR T cells or BiTE therapies. These are not things that we really are using in breast cancer. So to the extent that this is a breast oncology audience, probably not that relevant. Any of the 3 authorized vaccines are acceptable. Next slide. And again, this is just showing that, again, the timing. The only other thing they say is to separate a vaccine from surgery by a few days, but the reason for that has nothing to do with the safety or anything. It just has to do with the fact that the vaccine can cause a fever. And if a person who's recently had surgery or is about to go to surgery gets a fever, that can delay their surgery, or that can cause confusion about whether they may have a postoperative infection. So good to just separate that by a few days. Next slide. So immune checkpoint inhibitors, we don't use terribly often in breast cancer, although we do use these sometimes in patients with triple negative breast cancer. And this is reassuring. Remember, these drugs rev up the immune system, so there's a potential concern that they actually might cause more side effects for people with cancer who are on them if they get the vaccine. And in fact, this was not seen. So for people with cancer, with or without use of immune checkpoint inhibitor, the only side effect that was more common was muscle pain, and there was no evidence on laboratories of muscle damage. Importantly, there was no safety signal seen in patients who had had prior immune-related adverse events, so autoimmune medical conditions related to use of immune checkpoint inhibitors. This data is very reassuring. Next slide. So if you've gotten vaccinated, or if you're going to get vaccinated, and you should, you can help us continue to learn about COVID-19 vaccines by enrolling in Be Safe, which is a CDC program that collects information from patients. You can share if you have a medical condition on there like cancer, and they will reach out to you daily for the first week, and then weekly for the next, I believe it's 6 weeks, and then every 3 months after that. To just ask about any side effects you may be having from the vaccine and whether or not you've become infected with SARS-CoV-2. So you can actually aim your smartphone camera right at that code if you'd like to enroll now. Next slide. So there are a couple of trials I just wanted to make people aware of, and then I'm going to close. So this one is the Vaccination Against Cancer, Against COVID and Cancer trial, or the VOICE trial. This is a prospective study that's being conducted in the Netherlands. They will enroll 900 people with cancer who have advanced solid tumors, who are on chemo, immunotherapy, or both, as well as a control group without cancer. They will all be vaccinated. And this study started in February. They're going to be following these patients to look at adverse events they have, whether or not they get infected with COVID and the outcome of it if they do get infected, as well as immune correlates, the response in the blood that may help us figure out what it means if people with cancer are less likely to form antibodies or less likely to form T-cell responses. Does that have functional consequences in terms of protection? Next slide. The other study I want to make you all aware of, and I think that anybody who's listening to this who has cancer and who gets infected with SARS-CoV-2 should absolutely enroll. This is a prospective natural history study conducted by NCI of 2,000 people of all ages with COVID-19 and cancer. I won't go through all the eligibility criteria in the interest of time, but just to say they will be having you complete questionnaires, release medical records, and do blood draws to look at the natural history of COVID-19 in this population, and the clinicaltrials.gov identifiers down at the bottom if you're interested. Next slide. And then finally, just to finish with a global equity perspective in the last couple of slides, we've made great progress in the US. You see that we've vaccinated with at least one dose 43% of the total population and 55% of the total adult population. And we have more than a third of the adult population fully vaccinated. So this is great news. Next slide. Unfortunately, just as we saw with the disparities in terms of hospitalization and death by race, we see the same thing happening here. Once again, a consequence of structural racism, where we've got patients who are Black, patients who are Hispanic, Latino, being vaccinated at a lower rate than their white or Asian counterparts. And this is due to many things. It's been attributed a lot to mistrust of the vaccine, and I think that's part of it, but a lot of it is actually just a lack of taking the vaccine to where people live and work to make it easy for them to get vaccinated. Next slide. So again, the US is doing a great job here. The darker blue colors, indicate the countries that have vaccinated more of their population. Importantly, the places that you see in gray there have not yet begun. Next slide. So the US is in 11th place globally for percentage of the population that's vaccinated. We lead the world in the total number of people fully vaccinated. That's great news for us, but next slide. This is a problem for the world. So none of the 29 poorest countries in the world have even begun vaccination against COVID-19. Not even their healthcare workers taking care of these patients on the front line have received a dose. Only 26% of the countries that have any access to one or more COVID-19 vaccines are routinely immunizing people with cancer as part of their national vaccination strategy. And COVAX, which is a pooled procurement mechanism where essentially all the wealthier countries in the world contribute vaccines, and then they're equitably distributed in low and middle income countries, that only will cover 20% of the population of those countries. And it is currently unknown whether people with cancer will be prioritized or even included in those 20%. So this great progress we're making in the US, including in the US for people with cancer, is not being made around the world, and it's incredibly important. Next slide. So for anybody who's hearing this talk and being alarmed and thinking I'm not protected, I'm worried, just important to say a word here about herd immunity. So herd immunity reflects the concept that if you have enough of the population who is immune to a virus, whether that's immune from prior infection or ideally immune from vaccination, since the vaccination doesn't carry the same risk as getting the infection, if you have enough of the population immune, even if you have some people who are unvaccinated, or even if you have some people, maybe people with cancer and others who are vaccinated but don't form a good immune response, they're still protected because the likelihood that they will come in contact with one of the infected people becomes much lower. So it really emphasizes that all of us, particularly all of us who are adjacent to people with cancer, people they live with, the people who are their clinicians and so forth, people who work with them, really need to get vaccinated because that's a key component of protecting the cancer community. Next slide. So these are just resources here that if the slides are shared would be helpful to anybody with cancer or anybody who's caring for someone with cancer about COVID-19. Next slide. And the last thing I just want to say is there are combinations of monoclonal antibodies against the coronavirus that are available, 2 different combinations under emergency use authorization to high-risk patients age 12 and up if you've tested positive for SARS-CoV-2 in the last 10 days and are not hospitalized, mild to moderate symptoms. So you can go to the website there to learn more and to find an infusion site if you qualify. These have actually been purchased by the federal government. So when you receive these as an inpatient, as an outpatient IV infusion of about an hour or so, there's actually no cost to the patients. And these have been shown to reduce viral loads, and in the case of one of the combinations, to reduce the risk of hospitalization and death from SARS-CoV-2. Next slide. And I'll just close by saying, a quote from one of my favorite books by Albert Camus, The Plague, saying there's no question of heroism in all this. It's a matter of common decency. That's an idea which may make some people smile, but the only means of fighting a plague is common decency. So please continue to wear a mask, even if you're not personally worried about catching the virus. And please get your vaccine, not only to protect you, but to protect others who may not have access to vaccines or may not form a good immune response. And I believe my last slide is the next one, which is just my closing slide. I just want to acknowledge Dr. Stearns, who is my mentor since fellowship, as well as Dr. Smith and everyone who's been involved in planning this series, my Hopkins breast gyn colleagues, everybody who's taken part in COVID-19 studies so that we actually learn things. And I have something to say to you today, and everybody with cancer and all those who care for them. So thanks very much. And I believe I have my contact on the last slide, or at least my Twitter. I don't know if my email's there or not, but if you can go, yeah. So I'm on Twitter as TM Prowell, and my direct messages are open if you'd like to reach me. Thanks so much for your attention.
Thank you so much, Dr. Prowell. What a wonderful presentation, very informative. We have lots of questions coming in through the chat box, but first I think we'll turn to Nicole Tucker-Smith to hear about her experience, and then we'll do the questions and answers. Nicole is going to speak to us and give us the patient perspective, what it's been like to go through breast cancer treatment during the pandemic. As you can imagine, going through cancer treatment has a lot of challenges, emotional and otherwise, even when it's not during a pandemic. And as Dr. Prowell referenced at the very beginning, the pandemic has upended multiple aspects of healthcare delivery. And so we want to hear what that's been like. And then we'll turn to your questions. So Nicole?
Hi, everyone. Thank you for having me here today. Again, my name is Nicole Tucker-Smith. I am currently 44 years old. I was 42 when I was diagnosed with breast cancer in January of 2020. By profession, I'm an education consultant. Previously, I used to do a lot of traveling. Now, not so much, but I am able to still be active via Zoom, so quite used to that. And I'm a parent of 2. I have a 12-year-old and a 14-year-old. And I would say that, well, actually, just to give you a little bit of background. So my breast cancer that I had was, I was eventually diagnosed at stage 2A. I had a lumpectomy. My surgery was in March. I was probably one of the last surgeries right before everything started to shut down. I think it was like March 19th or something. And they said, thank goodness you're in this week because we don't know what we're doing next week. And so everything was just a heightened level of stress, I would say. So I had a lumpectomy in March of 2020, and then chemotherapy, I started that in May. and then radiation followed in August. And some of the challenges, I mean, obviously going through cancer treatment is challenging, but in particular, just having to be separated was really hard. So you could see with the chemotherapy treatment center, Hopkins has a really nice job of, you can tell that it was meant for somebody to go through it with you, that there were spaces for others to be there with you. And we had to do it on our own. So I was, I got dropped off, go in and go through the chemo for, several hours, and that was tough. But then also just in terms of people being able to care for you, having the support. The first time I went through the first round of chemo, I thought, okay, my kids are 12 and 14. I can tell them I'm going to be, not feeling so great, but they still wanted me to be mom. Like they still said, but why are you still in bed? Like, I know, what are you doing? And so the next round, we had to figure out a way for them to go stay with my parents. And it was tough because they're older and I want to make sure that they're protected. And even though kids are less likely to have severe symptoms and consequences, teenagers can transmit COVID. And so we basically had to have them quarantined for 2 weeks before sending them to my parents, because I just couldn't have them with me. It was tough. And then having to make sure that they weren't around anybody or anything as well. And then I think the other thing about that was really challenging going through it was recognizing that because the cancer that presented itself in me a little bit differently than some of the data, I had to make some choices about whether or not I did chemo. And I recognize the value of having data, particularly data that relates to how it's presenting for you. And so now I'm a bit of an evangelist for clinical trials, particularly clinical trials with diverse representation. Because when there's only so limited data, then it's hard to say what would be the best course of action. And so I could see firsthand that there were trials that were shut down, right? That they weren't having during COVID. And so that's a concern. Hopefully those can come back and that we didn't lose too much time and traction with that. And I've signed up for several trials and studies, and I have an app that I check into for some of those. But then there were also a lot of things that I learned. And if you're working with patients, or if you yourself are one, just find a group to talk to, even though groups can't meet face to face. The group that I've been a part of with Jill has been really helpful. I joined when I went to go see my primary care physician, and he asked me, so are you having any trouble sleeping? And I said, yes, of course I'm having trouble sleeping. I have all these things going on and I'm stressed out, and he said, you might want to find a group. And so I found a group, and that was really helpful, because even when you're talking to your friends, it really helps to talk to somebody else who's going through it. And then also, I think going through all of this helped me to be not afraid of a diagnosis. I realized that the diagnosis isn't the worst thing, that it would actually be much worse to have cancer and not know it. And for me, I'm very grateful for having been diagnosed when I was. The fact that I went in for my mammogram in December of 2020 before I might have decided otherwise. 2019. I went in for my mammogram December 2019 before things started shutting down in 2020. And my tumor was very, very small. It was so small that the first mammogram missed it. But I said, I feel something, and I pushed for an ultrasound, and then it was uncovered. And then we found out that just a very small amount had made it to my lymph nodes. And at first, when I found out that cancer had spread to my lymph nodes, I was devastated. But then, Dr. Stearns helped me understand that, before that amount might not even have been detected. And so I recognized that there's so much value in screening, and a diagnosis isn't the worst thing. And it made me less afraid of repeated screenings and getting screened, because what would have been so much worse is to have gone all of 2020 not knowing, and then still be putting off my mammogram now because of COVID. And I could have been walking around while the cancer was spreading.
Thank you so much for sharing your story. It's unbelievable bravery on so many counts. We have about 9 minutes left and lots of questions have come through the chat box. So Jill, I'm going to let you fire away with some questions.
Yes, thank you, Nicole. That was really brave to share your truth. And I think it means so much to everyone. And thank you, Dr. Prowell, for composing such a great presentation. I know you were working late into the wee hours as things were changing at 1 a.m. New papers were coming out and Dr. Prowell was still updating us. So you have the freshest, newest information if you're on this call. So thank you. One of the questions that I thought was interesting that I've heard a lot about is some of the pivot of the research resources, which went to COVID instead of cancer research. Is that going to, affect the drug development for cancer, the approval, and ultimately mortality with the shift in resources and really the pause in research with COVID?
Yeah, so thanks for that question. Actually, I'm trying to type answers to some of the easier questions in the chat as well. Yeah, so this was unquestionably an issue. We had diversion of resources, not only money, but humans, right? So we had study staff. I mean, I know Hopkins even had this. We had research study staff that were, diverted from screening patients for breast cancer clinical trials that were going and doing patient transport for people with COVID-19. It wasn't even necessarily the diversion from, one research topic to another research topic. It was like diversion entirely out of research. So yeah, there's no question that happened. People were diverted. Laboratories, resources have absolutely been diverted. Many labs that were working on cancer biomarkers and cancer tests, labs that had genomic, expertise. Suddenly everybody was trying to do SARS-CoV-2 tests because, as everybody on this call who tried to get a test knows, it was almost impossible to get a test for the first several months. And if you got one, it might take a week or more to come back, at which point it was not really helpful. So this is an absolutely huge issue. I think it's going to take a very long time to recover from that. I mean, that could be a whole talk all by itself, honestly.
Yeah, thank you. So I know a lot of people have also asked this: if someone is fully vaccinated and they want to see their grandkids, but they're concerned about not necessarily even just COVID, but other infections, is it safe to see those kids that aren't vaccinated outside with a mask if they're currently in chemotherapy?
Yeah, so, this is one of those things that I would say, there's no such thing as safe and not safe. This isn't like a light switch and it's either on or it's off. This is like a dimmer. And so you've seen the data there. We know that a lot of people with cancer, particularly heme malignancies, but even solid tumors, don't form a good immune response after a single dose. They form a much better immune response after the second dose, but still less than people without cancer. And data that I didn't show, some of the data that was coming out at 1 a.m, was that even for people with cancer who form an immune response, it's actually much lower levels of antibodies than people without cancer. So one study found that the antibody response was about half. So half, in terms of the actual percentage of level of antibodies in the bloodstream was about half. Another study found that it might be reduced by 10-fold or more in people with cancer than without. And that was particularly problematic for people on chemo. It was less of an issue for people on targeted therapies like HER2-directed therapies, like CDK inhibitors. But people who are on chemotherapy, were much less likely to form a robust antibody response, even if they formed a detectable one. So I would say this is something that you really need to, these studies that I mentioned to you, that particularly the VOICE study that we're going to get the results of probably in July from the Netherlands, will help us a lot to actually be able to say, what do these immune responses mean, right? Because what you don't care what your antibody number is. You don't care what these T cell numbers are. You're not in a position to interpret them. And frankly, as an oncologist, neither am I. What you care about is, am I at risk? We don't currently know what level of these things you need to be protected. So some of the questions I'm seeing in the chat are like, should I go get my antibodies tested, et cetera, et cetera? I would say no, but enroll in that study. If you enroll in any study you can. So if you get infected, please enroll in the NCCAP study. Let's wait for those data. If you can do this as part of a clinical trial, I think it's valuable to get these tests done. The problem is, if you go get them done, I don't know what it means if you have antibodies present. I don't even know what it means if you don't, because T cell response is an important part of protection, and our commercially available tests don't detect that. So you can go get a semi-quantitative antibody test. It's available through even Quest. I mean, this isn't like a special thing. I just don't know if you have a positive test, does that mean you're safe? And I don't know if you have a negative test, does that mean you're unsafe? So what I would say to the person who, wants to see grandkids that are not old enough yet to be vaccinated, or who might be in school or having other contacts, is it does expose you to some risk. You can minimize that risk dramatically by being outdoors, where any virus that they might be shedding is getting diluted in the air. You can minimize that risk dramatically by staying in masks and staying 6 feet apart. I think that if you're vaccinated and you're seeing kids you're wearing a mask, they're wearing a mask, you're 6 feet apart, I'm absolutely comfortable with that for anybody at this point, even a person on chemotherapy, if you've had both doses of vaccine and 2 weeks have elapsed. Or for the case of Johnson & Johnson, which is a single dose product, you've had that 1 dose and you've had at least 2 weeks elapsed. I'm looking at the other questions in here. I know we're short on time.
So there was one about the 2 dose versus the 1 dose. Is the lymph node swelling possible from that? Just to follow up from what you were just saying.
Yeah, so the data that we have on this, now remember, people with cancer were basically unrepresented in these clinical trials. So I'm giving you these data based on a population that by and large is not affected by cancer. But what we saw was that the vaccine that had the highest incidence of lymph node swelling or lymph node pain after vaccination was Moderna. And then Pfizer was lower and Johnson & Johnson was lower still, Johnson & Johnson being the single dose one. But would that be a reason to make me choose one of these over the other? It really would not, especially given that, the slide that I showed you showing that people with cancer were just less likely overall to have any adverse events, including lymph node swelling. I don't think that I would choose a vaccine based on that risk. And somebody asked, do we know anything about lymphedema? We really don't, because unfortunately, without having people with cancer in those clinical trials, folks who haven't had a lot of axillary lymph node surgery or radiation, lymphedema is a super rare event in those patients, in those people. And so even if they form lymph node swelling, those are people who aren't really high risk to get lymphedema to start with. It's another reason that we really need clinical trials to reflect the whole population. I wish people with cancer had been included in these vaccine trials in their own separate cohort, where if the efficacy or the safety were different, at least we're still getting information about that in a randomized trial without necessarily confusing the picture of the overall study, because the efficacy and safety profile probably are different. We're already seeing that, but it would be nice to have that data from randomized trials.
I think a good question to end on is, how do you convince people, since there weren't cancer patients in the vaccine trials, how do you convince reluctant cancer patients to get the vaccine? And I know you've done a wonderful talk, and throughout your talk explained why we need to get vaccinated. But is there anything you can say to that reluctant cancer patient who wasn't in a trial why they should be vaccinated?
Yeah, it's an absolutely great question. And the highest quality evidence comes from randomized trials. So it's a great question. I think what I would say is we now have these small studies, the 2 that came out at 1 a.m., to my dismay, as well as some of the ones that I showed in the talk, that enrolled 100 patients with cancer or something, and then enrolled, 25 healthy controls, where we see that people with cancer are less likely to form a very robust immune response, and they are less likely to form antibodies or T-cell response in general, but it's not zero. And, we're still talking about at least half of the people, even in the worst of cases, having protection if they have the full series that's required, 2 doses for Pfizer or Moderna, 1 dose for Johnson & Johnson. If their antibody levels are a little bit lower, or they're a little bit less likely to form that immune response, it's still better than what you have if you don't get vaccinated, which is 0. Mm-hmm. And so without knowing which group you're going to be in, and knowing that the side effects are very few, for most people, it's going to be a sore arm and a little fatigue that's mild. There have been no cases of people with cancer having severe enough adverse events related to vaccine to need to be hospitalized or to die. So what I would say is, given that we know that COVID itself, the virus itself, takes the lives of about 1 in 7 people who have cancer who get infected, and about 1 in 3 people who have cancer who get COVID and get sick enough to need to be in the hospital, that is just an absolute no-brainer question that the vaccine is a better bet.
Okay,
any protection is better than none.
So I think we are at the top of the hour. Thank you for answering all of those great questions. As a reminder, we will be sending out a link for the evaluation, and we really, really would love to hear from you so that we can continue to plan other activities and to educate. Next slide, please, Jackie. Oops, sorry. So a big thank you to Dr. Prowell and to Nicole Tucker-Smith, and also to our sponsors for this Lunch and Learn series, the Jane Rice Survivorship Program in Breast Cancer and the Centers for Disease Control and Prevention. Next slide, please. Actually, one more slide. So a shout out for the next webinar in our series, which will be held on Friday, May 21st. And it will be presented by Dr. Roseanne Scheinberg, who is an expert in integrative medicine. And the topic is Thriving in Summer, Steeping in Sunshine and Nature for Optimal Health. And with that, we will close. Thank you to everybody for helping plan this. And thank you so much for our presenters. And thank you to all of the participants for your excellent questions and a great discussion.
Thank you. I'm trying to still answer a few questions in the chat. If anybody has questions left over, thank you so much, and feel free to reach out on Twitter in public or via direct message, and I'm happy to take them. Thank you again for having me.
Thank you.
Bye.
Thank you for having me as well.